Hello, and welcome to the Pharmacologic Management of Insomnia. I am Sandy Robertson, clinical pharmacist with Atrium Health Cabarrus. I am with Cabarrus Family Medicine Residency Program, where I have been for 25 years, and I'm training family medicine residents and attendings, and certainly insomnia is a big topic that we cover. I really appreciate you being here today. I'd like to start off by thanking the Primary Care Education Consortium and also an educational grant that is from Insomnia Pharmaceuticals. We really appreciate the time and effort that they have taken to allow us to provide you this education. The AAFP has reviewed pharmacologic management of insomnia and deemed it acceptable for AAFP credit. The term of approval is from March 1st until February 28th of next year. Physicians should claim only the credit commensurate with the extent of their participation in the activity. Following this CME event activity, participants will have the opportunity to earn an additional 2 prescribed credits for participation in each translation to practice exercise. Information on translation to practice will be shared within the activity. This is one of the coolest parts of this extra 2 credit. If you simply complete the survey that will be sent to you approximately 6 weeks later, then if you have invoked changes based on this educational grant and this presentation, then you will receive 2 extra hours of credit. The American Association of Nurse Practitioners Certificate Program and the American Nurses Credentialing Center accept AAFP prescribing Category 1 credit. For faculty disclosure, I think it's important that you recognize that any off-label or experimental or investigational use of drugs or devices will be disclosed by me. I will be talking off-label today in the Pharmacologic Management of Insomnia, and we take that very seriously. I'll give you a moment to read the remainder of this policy. Specifically for myself and for my partner, Michael Hannock, we have no disclosures to report, and all relevant financial relationships have been mitigated, and in my case, there are none to report. So let's get started on the fun part. What are our learning objectives for today? So we are going to just briefly go over the physiology of the sleep-wake cycle as it relates to insomnia. This is not something we're going to go back to school for, but you do need to have just a basic understanding of the physiology of insomnia and sleep-wake. Secondly, let's try to identify patients with insomnia routinely by asking, knowing what their behaviors are, and the recommended diagnostic methods for really looking into this chronic disorder. Thirdly, let's select appropriate pharmacologic treatments for patients with insomnia when indicated. Pharmacology is not always the answer, but when indicated, and these are going to be based on patient characteristics and risk-benefit ratios. We all know about risk and benefit and shared decision-making, and that is going to be a lot of what we're going to talk about today with who is the right patient. And finally, I think it's time for us to become more familiar with the newest class of medications for the treatment of insomnia called the DORA class. And sometimes you're going to want to incorporate this class of medications because it is in fact going to be the safest and perhaps the most effective for a selected patient population. This will of course be as part of a multimodal treatment approach where behavior changes are going to be key to success. But I'm hoping that you'll have an understanding of this class of medications if you really don't feel that comfortable with it at the beginning of this program. So here's our basics on pathophysiology of insomnia. You have 2 large neurotransmitters, the eros and the VLPO. The ascending reticular system, or the eros system, is what drives your wakefulness. It's what keeps you awake during the day, as opposed to the ventrolateral preoptic nucleus, which is what influences our sleep. So you don't really have to remember those, but what I would like for you to remember is orexin and GABA. Now, we all know about GABA, right? We have so many medications that are used to help to either agonize or antagonize GABA, but orexin is something that at least here in North Carolina, our residents aren't all that familiar with. So the orexin receptors, these neurotransmitters, is what's responsible for the wakefulness during the day. And then the GABA is conversely what's responsible for the drowsiness and the sleep at night. So when we antagonize or agonize the orexin receptor or the GABA receptor, we are going to offset that balance. So if you agonize the orexin receptor, then supposedly you should be more awake. Conversely, if you antagonize it, it's going to decrease your wakefulness. The opposite is true with GABA. So when you agonize your GABA receptors, that makes you more sleepy, and then antagonizing it does the opposite. So orexin and GABA, those are the two receptors that we really need to understand with regards to the system of the pathophysiology. Okay, and that's it, I promise. That's the most scientific we're going to get. Okay. So I really like the numbers. So what are these numbers? I'm going to give you a second to look at 50, 30, 100 billion, and 10. So what would you think these would mean? Well, 50 is the percentage of primary care patients reported to experience insomnia. 30 is the percentage of patients who mention this problem to their PCC. A lot of people do not want to talk about their trouble sleeping. I'm sure you can guess 100 billion is the direct and indirect cost of insomnia in the United States. This is with accidents, medical leave, disability, other medical problems. And finally, 10 is the percentage of patients who meet the criteria for chronic insomnia. Now, I'm sure most of us have had trouble sleeping at some time in our lives, right? It's episodic insomnia. We all kind of have experienced that. But when this disorder goes on for more than 3 months, and I'm going to give you the criteria for that, that is when it goes into what used to be called chronic insomnia or insomnia disorder by the DSM-5 criteria. So we have 10% of our population that are struggling with that. So keep that in mind when we go over some of these consequences. Okay. I want you to get really introspective here and really be honest with yourself, because as healthcare providers, we are probably the worst at sleep hygiene. All right, so what are some strategies to combat episodic insomnia? I have these little pictures here to kind of lead you. So one of the most important things is a consistent wake and bedtime in a cool, dark environment. Do you consistently go to bed approximately the same time and wake up, even on weekends, even when you're not sleeping well? Okay. Do you allow 7 to 9 hours nightly? I don't know about that. That is what the American Academy of Sleep says that we need. Do we avoid substances, food, and activities before bed? So let me talk about that. Substances are either stimulants like caffeine, coffee, tea, anything with caffeine in it, or it can be a CNS depressant like alcohol. So while alcohol does make you relaxed and actually does make you sleepy, the short half-life of alcohol oftentimes wakes us up and disrupts our REM sleep. So it's advised that for both caffeine and alcohol that they're avoided several hours before sleep. A heavy meal is something else that can really disrupt our sleep. So a heavy meal right before bedtime is something that's avoided. And then the big one is avoiding electronics. And this is the one that I know that clinicians are not good at. So do you have your phone, your laptop in bed with you? Are you scrolling? Are you doing charts? Are you watching TV? Do you have electronics going on in your room? Because the recommendation is to avoid all of that for 1 hour prior to going to bed. In addition to that, it says never, ever, ever put it in your bed. Okay, so no phone, no laptop, no TV while you're in bed. And then in addition to that, none of those anywhere in your house an hour before you go to bed. So the National Sleep Foundation did a survey of 1,000 adults, and they graded them A through F on such sleep behaviors. And I want you to know, these are people that didn't have insomnia, and I want you to know that 33% of American adults failed a grade of an F, and only 9% got an A. So what do you think your letter grade is going to be? And be honest with yourself before you start judging your patients, right? So I'm giving myself a B-. I'm like barely hanging on. I just can't get rid of the phone. That's what I'm really struggling with. So really think about that whenever you're talking to your patients, and it will really help you with good sleep hygiene. Okay? So what is insomnia disorder? So DSM-5 really differentiates between primary and secondary insomnia, and they now link it to insomnia disorder. So if you have, the definition is frequent and persistent difficulty either initiating or maintaining sleep. They define that as 3 or more nights per week. And then also if you have daytime symptoms. Those daytime symptoms can include sleepiness during the day, depressed mood, agitation, irritability, drowsiness. Those are your daytime symptoms. So if you have frequent and persistent plus daytime symptoms that last for 3 months, that is what the DSM-5 criteria categorizes as insomnia disorder. So why is that a big deal? Is it okay? Do we just need to just say, you'll get over it, just keep doing it? Well, there are consequences to insomnia, and these consequences are real. I was actually shocked whenever I started reading all of the different surveys and all the different reports, because there's so many diseases in primary care that I sometimes forget that insomnia in and of itself is an independent risk factor for other problems. So we obviously know about disability or medical leave. That's a problem for the public health and for everyone, for our families. Traffic accidents, that's a no-brainer. But I was shocked to find that depression, anxiety, alcohol use disorder, and psychosis are all increased risks if you have insomnia. So they can be bidirectional, just like other medical illnesses, but insomnia can feed into depression and anxiety. I'm sure you can all understand alcohol use disorder and other substance use disorders, as a matter of fact, because of the insomnia. I was also shocked to read that Alzheimer's disease, the relative risk goes up tremendously in older adults who have insomnia to later in life be diagnosed with Alzheimer's disease, and that is kind of a frightening statistic. Just like mental health disorders, other health disorders like hypertension and cardiovascular disease can worsen insomnia, and then insomnia can in reverse worsen your hypertension. Certainly when a patient is not sleeping every night, their blood pressures typically go up if they already have hypertension. Cardiovascular disease can be negatively impacted. And then finally, and this one was very shocking to me, the increased risk of mortality in older adults is you're twice as likely to die if you go for long periods of time with insomnia versus older adults that are otherwise healthy that do not suffer from insomnia. So there's some real consequences to this. In fact, this is something that we really need to start addressing as one of the many things when we're talking to our patients about their overall health. So how do you assess for insomnia? Well, the big obvious answer is to ask. Now, I work with a lot of clinicians, and when you're already behind on your day and you've already addressed 4 other problems and you are getting ready to leave and your patient says, hey, can you send me in something for sleep because I'm just not sleeping very well? That is always that time that just gives you that heaviness and you just really don't want to deal with it. So it's hard for us to ask that question. But I would encourage you to ask up front, do you have trouble getting to sleep or staying asleep? Do you feel well rested during the day? And if you find that the patient, whenever you're asking that, is giving you information that, okay, this could be a problem, then you need to state that this is a problem. And it is such a problem that I would like for you to come back to perhaps talk about this in his own visit, okay? Take this seriously. So, number 1, ask. Number 2, look at all the other medical and psychiatric comorbidities, the medications. We're going to go over that in the next slide. A sleep diary is your next best step, okay? When you have nothing else to do, ask the patient to do some homework. You need some objective data to help you lead through this problem that they're having. And then finally, we have several validated indexes that can really help you assess the severity. The Insomnia Severity Index, the Pittsburgh Sleep Quality Index, and finally the Epworth Sleepiness Scale. All of these are used in all of the clinical trials of pharmacologic and behavioral management of insomnia. And this is a really good way to go down, and it really helps the patient kind of to reinforce the behaviors that are good and not good and kind of how much they're suffering from their insomnia. So when you're going down the route of trying to delineate, your insomnia and look at your comorbidities, it's important to look at first, what are the comorbidities outside of your hypertension, cardiovascular, respiratory, because there are lots of things that are linked to insomnia, including malignancies. Certainly going through chemo and radiation, we know that that corresponds with insomnia. In addition, rheumatologic, lupus, RA, all of these conditions really increase your risk of insomnia, diabetes, thyroid disease, and then finally just your cognitive impairment, your dementia. All of these comorbidities coincide with an increased risk of insomnia. Next, you really have to ask the question, this is time to get honest with your patients about substance abuse or dependence. You have both stimulants and depressants that can influence your sleep-wake cycle. So in your stimulant category, you have nicotine, caffeine, cocaine, and amphetamines, either recreational use of amphetamines or medications that we prescribe. These are things that you could potentially modify or at least have a discussion about to try to modify. And then you have the opposite of that. You have alcohol, THC, and opioids. Again, whether you are withdrawing from those or you're consuming too much, you're sleeping during the day, there's all kinds of ways that this can really influence and impair your ability to sleep soundly at night. And then, of course, as a pharmacist, I'm always going to make a medication list, right? So there's a lot of stimulants that we prescribe, and most of them have a half-life that they should be out of your system by bedtime, but that's not always the case. So really taking a hard look at that, making sure the patient isn't taking more than is needed or combining an extra amount of caffeine when they're using their stimulants. SSRIs and SNRIs are notorious for causing insomnia, especially with increasing the dose or when you first start out those therapies. So that is something to try to encourage the patient that it would perhaps get better with time. Bupropion and varenicline are pretty classic to even increase more the rates of insomnia if a patient is going through smoking cessation. So when you are withdrawing from nicotine and then you're substituting bupropion or varenicline to try to offset your cravings and you're trying to stop smoking, then insomnia rates are close to 50 to 60%. So just trying to walk a patient through that and hope that they can get through that within the next few weeks is very helpful. And then we all know the stories about steroids. You get your prednisone dose pack and you can't sleep for 2 weeks. So I'm not saying that you have to treat that all the time, but just understanding and helping your patient to understand that this could be a short-lived consequence of some of these medications. So I have a patient for you. I want you to meet Mrs. L, and Mrs. L is going to kind of go through her journey of insomnia and hopefully kind of lead us down the path. So Ms. L is a 64-year-old patient that you've known for a long time. She has hypertension and depression. Those are both well controlled. And she has recently started a new job as a bus driver for an elementary school since the passing of her husband 6 months ago. During her visit today, she mentions to you how tired she is and that she's just not sleeping well. So, being the good clinician that you are, you further discuss this with her and you talk briefly about her sleep hygiene, that you don't have a whole lot of time, and you ask her if she would complete a sleep diary for you and to return in 2 to 3 weeks just to have a discussion about her sleep. And this is her sleep diary. So she followed directions, she came back. That's always a great patient. If you're not familiar with a sleep diary, there is one that you complete when you wake up in the morning and then another when you go to bed each night. And it asks you a whole series of questions, but it really helps to the patient to kind of quantify how much sleep, kind of what they're doing, and it truly is a diary. So when we go through Mrs. L's diary, it looks like, even though she's going to bed at 8 or 9 o'clock in the evening, she needs to get up early because she's a bus driver, and it looks like that she's only getting 5 to 6 hours of sleep at night, and she is waking up 1 or 2 times every night. So this looks like a sleep onset and a sleep maintenance problem. And whenever you're looking at her naps and other medications, alcohol, heavy meals, that's all of the items in the blue, things are looking pretty good, but you can definitely tell that she is struggling. So she comes back and she, like I said, she completed her sleep diary and she started taking melatonin supplements, 5 milligrams during the second week, but she didn't really notice an improvement. Upon questioning, she admits to you that she scrolls through her social media in bed when she's frustrated about not sleeping, and she always sleeps with the TV on, but with a very low sound. She doesn't think that's going to affect anything. She did take diphenhydramine and acetaminophen one time, but she had excessive sleepiness the next day, and that is unacceptable given her profession. She needs to be very alert for all these children. You did repeat her PHQ-9. Her score is 8. You feel like that's okay. You talk to her about grief and about depression. And she says, I am lonely, but otherwise I think I'm okay. So, what is going to be our first line treatment for Mrs. L? And the answer is, I'm sure you're not shocked, it is behavior change. It is cognitive behavior therapy / insomnia. So CBTI is a whole thing, and it is very advanced. This is a package. There are a lot of different modes that go into this cognitive behavioral therapy for insomnia. And to do it properly, kind of the gold standard is 6 to 8 sessions with a licensed therapist for insomnia that are about 60 minutes each. But in addition to your traditional cognitive behavioral therapy that we're all used to in primary care, there are 3 other strategies. The first one is stimulus control. Now, it sounds like stimulus control is to cut down on stimuli, which is kind of true, but that's kind of sleep hygiene. Your caffeine, your nicotine, your excessive exercise late at night. Stimulus control, what that really means is forming an association in your brain that the bed is for sleep, okay? And nothing else. Now, a lot of times what we'll say is the bed is for sleep and sex, and then everything else needs to be done out of bed. And you need to have a set time that you get in the bed, and then you get out of bed. When you get in the bed and you're not going to sleep, after 15 to 20 minutes, you should actually remove yourself from the situation, go try to calm down, do other things, read a book, do something mundane, and then try to return to bed. That is really what stimulus control is to form an association that the bed equals sleep and nothing else. Now, sleep restriction is an activity that not everyone can do, but it actually has proven to be very effective. Sleep restriction is when you calculate up how many hours you're sleeping at night. So let's say Mrs. L was sleeping 5 to 6 hours a night. She needs to be up at least by 5. Okay, so if she's willing to do this, she would wait and not get in the bed at 9 o'clock at night, but get in the bed at midnight. So she would only have 5 hours between midnight and 5 a.m. in which to sleep. Now, prior to midnight, she doesn't need to nap. She shouldn't drink any caffeine. She should really just try to get very, very sleepy so that when she gets in the bed at midnight, she has a better chance of going to sleep. Then that may take a few nights, and then if that starts working well and she's sleeping her 5 hours, then she can move that up by 30 minutes every few nights, and she can work her way back up to a healthy amount of sleep, which is 7 to 9 hours. Now, this takes time. It can be a little rough at times. The patient really has to be invested, and you can have some sleepiness during the day, so you have to be careful with people that drive buses and do things like that. So not everyone can do it, but it is an excellent strategy if you have the time to make that work. And then the third aspect of CBTI is relaxation, which sounds really easy, but it's the intentional process of once you're in the bed of tensing your muscles and relaxing your muscles and then releasing all of the problems throughout the day through your brain. So that is what a therapist helps you to get through. I want you to think about CBTI as multimodal or a bundle, like insurance. So this is insurance for your sleep. So when you bundle everything together, it's going to be better than each individual thing. Now, sadly, in our organization, we only have a couple of CBT insomnia specialists, and they are booked all the time, and they are expensive. So while we try to send a lot of our patients that way, oftentimes we're the ones trying to give as best we can behavioral changes and strategies for our patients. So I would advise you to look in your community and see what your resources are. Again, these are 6 to 8 sessions. And the American Academy of Sleep Medicine, as along with every other organization, says that this is by far the best way to reverse insomnia and to have better sleep behaviors, because the long-term effectiveness and safety profile is just far better than any pharmacologic agent. I think we could all agree with that. But what if CBTI doesn't work? And these are all the medications, there's a lot of them, that we have prescribed before. I think I've seen every single one of these. And we're not going to have time to go over each and every one of them, but we are going to hit many of them. We have the sedating antidepressants, the melatonin agonist, Melatonin, the benzodiazepine receptor agonist, also known as the Z drugs, which are, first cousins to your benzodiazepines. And then you have your DORAs. And then on the right-hand column, you have kind of your less used ones, except for maybe the antihistamine, so diphenhydramine, doxolamine. And I've never personally seen the anticonvulsants used just for sleep, but that certainly is reported in the literature. So take a moment. I want you to look at these medicines and think, okay, what's the one that's my go-to? What is my first and second line that I just automatically go to? And then let's see if you feel good about that, or if you think maybe I could improve on that towards the end. So I want to do a receptor breakdown for you. This is very, very easy. And I want you to think back of GABA and orexin. Okay, so you've got the red GABA and the teal, is it? Orexin. So your benzodiazepines and your benzodiazepine receptor agonist, aka the Z drugs, that is all GABA. As opposed to that, your DORAs are all orexin. So your DORAs are dual orexin receptor antagonists. So they antagonize the orexin A and B receptor, whereas your benzodiazepines and your Z drugs are agonists to your GABA. So we already went over that and we kind of understand that. Your histamine, we all know histamine 1 has a side effect that when you antagonize that, you are going to have drowsiness. And all of your antidepressants, as well as your, first generation antihistamines, all bind to histamine 1 to result in that drowsiness. Okay. Now, in addition, your trazodone, amitriptyline, mirtazapine, and quetiapine also bind to alpha 1 and 2 and serotonin. And so they think that it's just a cocktail for those particular medications as to how the drowsiness comes. My question to you is, does the drowsiness really come, or do we just think it comes? Okay, so we'll talk about the efficacy in just a minute. And then finally, you have your melatonin 1 and 2. So melatonin, very, very important for circadian rhythm. And Melatonin we'll talk about is just the kind of the high affinity receptor agonist for melatonin for circadian rhythm problems. Okay, so here's your receptor breakdown. So let's talk about the orexins first. I know it's the newest class, but it's so intriguing to me that these neuropeptides were only discovered in 1998. And it was truly the scientists that were looking for treatment strategies for narcolepsy, not insomnia. Okay, they were looking to identify these neurotransmitters, these neuropeptides, and to hopefully increase the wakefulness. And I will let you know that there are phase 2 and phase 3 trials currently going on for orexin agonists for the treatment of narcolepsy. So that's very encouraging. But in that research, what they were able to identify is that if we antagonize these receptors, can we therefore treat insomnia? And the answer is yes. So the orexin pathophysiology is very central for the regulation of sleep and wakefulness and the maintenance of arousal. So you have your DORAs, your dual orexin receptor antagonists. We have 3 of them that are FDA approved for the treatment of insomnia: suvorexant, levorexant, and daridorexant. Daridorexant and levorexant, honestly, I don't know if just what was currently going on in our world with the pandemic and somehow I think we just kind of overlooked some of these medications. I know that I personally did. I had a hard time keeping up with everything in addition to what was going on in our world of COVID. But suvorexant, you probably remember back in 2014, but daridorexant was just approved just a little over a year and a half ago. So it's relatively new. So now we have 3 medications in those classes. So what do you need to know about the DORAs? Number 1, the DORAs work by reducing arousal, but it's really interesting. It preserves the person's ability to awaken in response to auditory stimuli. So, the example is if I take this medication and I'm asleep and my child cries, am I going to be able to wake up? And there are studies that say the answer to that is yes. So that is very encouraging. All of the DORAs are FDA approved for sleep onset and sleep maintenance insomnia. And the studies are going out to 3 months. All of the phase 3 and phase 4 trials have gone out to at least 3 months. Some of these trials have gone out to 6 months, so that's very, very positive. And the great news is there's continued efficacy and a low risk of rebound insomnia. They have deliberately given placebo. It's randomized, placebo-controlled. At 3 months, they've changed it from medication to placebo, and there was no rebound insomnia. So that's very, very encouraging. And then the next day cognition data is also positive. When they assess the next day, even when you don't describe daytime sleepiness, the cognition scores are still very high. So that's all very positive news about the DORAs. There are some differences in the pharmacokinetic half-life that I just want to share with you because I'm a pharmacy nerd. Suvorexant has a half-life of 12 hours. Limborexant is 18 hours, and daridorexant, the newest one, has the shortest half-life of 8 hours. And that is very significant whenever you think about liver processes and elimination and metabolism. So I just wanted you to be aware of that half-life difference. So let's start with dosing. Basically, you want to make sure that it's within 30 minutes of going to bed, okay? They have, this is just from the package insert, so within 30 minutes, you want to start with the lowest dose, obviously. All of these medications have a titration up that you want to carefully bring the patient back, so that the dosing is pretty simple. Go to the far right as far as additional info. Let's do that next. You do not want to give this class of medications to people with narcolepsy. Now, there is going to be a day, I think, when we better understand the orexin system, and perhaps we are going to be using orexin agonists for the treatment of narcolepsy, but right now we do not want to mix up and antagonize more of the orexin with patients with narcolepsy. In addition, these patients need to have a functioning liver so that they can metabolize this medication, and they cannot have sleep apnea. It is not well studied in sleep apnea, and we show excessive sleepiness the next day whenever you have those patients. So those are not good candidates for this class of medication. In addition, this is very important, all of the DORAs are cytochrome P450-3A4 substrates. So they use that 3A4 to be metabolized. If you are on a strong inhibitor, such as the azole antifungals or some of the HIV medications, it is contraindicated. It is not a good idea. These drugs need to be metabolized. But I would also encourage you, if you have a moderate inhibitor, such as diltiazem or grapefruit juice, that is something that you need to monitor for. And if you feel like this is the best medication for the patient, start at the lowest dose and have a very close follow-up with your patients. In addition, just know that the time to sleep is delayed with a high-fat meal. So if you eat a high-fat meal and take your medication and get in bed at the same time, it's not going to be the onset is not going to be as quick. This is a scheduled medication, and it is still expensive. These medications are relatively new, and so you have to think about them with, how can the patient afford these, and kind of use your strategies that we use for all the other chronic diseases. Now, I saved adverse effects for last. Headache and dizziness have about a 5% incidence, and that is similar to placebo, so that's great news. The rest of the symptoms are kind of your narcolepsy type symptoms. And it's very alarming when you read in the package insert that you have to counsel a patient on sleep paralysis or hallucinations. And I will admit to you that back in 2014, when suvorexant came out on the market, it was a little frightening. I had to look up what sleep paralysis was. I didn't understand narcolepsy all that much. And it is something that you need to discuss with your patient. But I'm very happy to report that we have some pretty robust evidence now with a meta-analysis on what is the percentage of, or what is the likelihood that this could happen. So I just want to share that with you. So daytime sleepiness, okay, if you look at over 1 to 3 months with the 3 medications, it is going to be 0.01%. So that is a very, very, very low percentage of even daytime sleepiness, much less than I thought it was going to be. Sleep paralysis, which is probably the most frightening of them, is even more rare. So that is 0.003 to 0.02. So these percentages are so low. You do need to talk to your patients about them. But I certainly, as a pharmacist, can give you lots of examples of lots of adverse effects that happen that are at a higher frequency than these percentages, okay? And then lastly, these hallucinations that you might experience whenever you're going to sleep, again, they do happen. It's not zero, but it is a very, very, very low percentage. I do want to say that suicidal ideation has been reported to the FDA. That is something that we always need to take seriously with any of these medications. Anything that affects your brain and your sleep and your cognition can potentially affect that. So just talk to your patients about it. It's important to have a relationship with them so that they will feel comfortable coming to you with any type of feelings and vulnerabilities that they have with regards to suicidal ideations. All right, so let's move from the DORAs to the Z drugs. We know that benzodiazepine receptor agonists were created for sleep. They are sedative hypnotic agents. They do not have anxiolytic effects compared to the benzodiazepines. They have a lower risk of tolerance, abuse, dependence compared to the benzos, and they have only been studied with short-term use. So the package insert still to this day recommends 4 weeks or less with these medications, and ideally not every night. Okay, and we'll talk about why. So it kind of depends on what you're comparing these medications to. So when you compare the data with the Z drugs compared to benzodiazepines, the profile is safer. But when you compare them to other classes, maybe not so much, okay? In addition to that, you have to be very careful with your dosing, and you have to look at gender and age specifically for zolpidem. So zolpidem has the most data with it. It also is available in the most forms. It has immediate release and a nasal spray. In addition, an extended release formulation. So for your immediate release, for men, the starting dose can be 5 to 10, but in women, it should only be 5. Okay, so we have studies to know that women are more pronounced to have the excessive sleepiness during the day, the following day. They have a slower clearance. That is also true for the elderly. So if you have an elderly patient that you feel that this is the best medication class to use and zolpidem is what you want to use, do not use more than 5 milligrams. And I would even advise that you don't go up. If it is not effective, then you need to abandon ship and go to a different medication. In addition, the ER formulation, the doses are a little bit different, but you can see them here. And in the package insert, it says, do not perform next day activities requiring complete awareness for anybody if you're on an extended release formulation. In addition to the zolpidem, we have the other medications that probably aren't as popular, but they do have just a shorter half-life, and they have some unique considerations. We have unpleasant taste with azopliclone. It's hard for me to say that word. And then zaleplon is really interesting. It only has a 1-hour half-life. So what you need to remember is that it only has sleep onset approval by the FDA, so no sleep maintenance. The other two do have sleep onset and sleep maintenance, okay? But it has a really short half-life, so that can be good or bad. So here's where the rubber meets the road, and this is where it gets a little bit difficult. In addition to the FDA saying this is only for short term, less than 4 weeks, we've got this black box warning that came out in 2019 for all 3 of these medications that state complex sleep disorders such as sleepwalking and sleep driving can result in serious injury or death. And this is just subsequent to many, many years of FDA reports, court cases, tragedies, fatalities, things that we've heard about sleep driving. I will tell you that I have reviewed probably 150 of these cases. Just you can go on the FDA website. Many, many of them are when you combine other CNS depressants. Now, before you judge, it can be something as simple as I went to dinner, I had a couple of glasses of wine, and then 3 hours later I took my medication, and now I'm 10 miles down the road and I don't remember driving. So it's not like they're ingesting a tremendous amount of alcohol or a benzodiazepine. Sometimes they're prescribed both. They're prescribed the benzodiazepine for a panic attack, and then they're prescribed their other medication for sleep. And when they combine the two, this does tend to increase the risk of complex sleep disorders. But These complex sleep disorders have also been reported just with the Z drugs used independently. So just be aware that you need to talk to your patients about that. The adverse effects, I'm sure you guys have all seen, very low risk of headache, dizziness, but confusion, next day drowsiness, falls, amnesia, pretty commonly reported, as well as rebound insomnia and withdrawal. It is very difficult to stop this cold turkey. This is a medication that you will need to taper down, or you just need to expect that your insomnia will return. So whenever you're trying to look at the long-term effectiveness and really trying to help a patient with insomnia, it gets very difficult whenever you're prescribing these, when you go more than a month out. Okay, so before I got started, there was a survey question. I hope that I just answered it for you. So let's go through it together. Zolpidem 10 milligrams at night is most appropriate for. So I know this was kind of a difficult question, and we could argue it, but out of the four, the best answer is A. A 45-year-old man with heart disease doesn't have any kind of relative contraindications, and the 10 milligram dose is the key here. So B, the 67-year-old female, she's elderly, so she should be on 5 milligrams. The 40-year-old who drinks alcohol, we do not mix that. Unless they stop alcohol, that you do not need to mix those medications with alcohol. And then lastly, if you have your CDL and you're a truck driver for a living, that is not something that's recommended that you give this class of medications to. So I hope that was kind of an easy answer for you. So in the benzodiazepine class, I really struggle with this one, okay? And I'm not a benzodiazepine hater, but there are a lot of problems that come with it, okay? I only want to include temazepam and triazolam because these are the only two that are even indicated for the short-term treatment of insomnia. So they're only indicated for 2 weeks of treatment. So I'm not saying that you can't do it, but this is not a road you want to go down chronically. And we've all been there. We've been there for anxiety and sleep. And now here we are 2 years later trying to get a patient off of their clonazepam. So the reason why we need to be careful is because of all the adverse effect potential. The next day fatigue, the drowsiness, the amnesia, the depression that has been shown, it actually has a converse relationship with anxiety and depression long term. The falls and the fracture list, of course, is on the Beers list for unsafe medications in the elderly. The additive effects with alcohol, the abuse potential, the withdrawal, the tolerance, all of these things are reasons why we probably shouldn't be prescribing benzodiazepines long term for insomnia. Okay, let's switch gears a little bit, and this potentially could be something that helps when your circadian rhythm really needs help. The recommendation from all the societies is Melatonin because it's 3 to 5 times more selective in its affinity for these melatonin receptors. Over-the-counter herbal supplements of melatonin, they're safe, but what we have found in study after study after study is that it's no different than placebo. But the Melatonin actually is an extended release. It lasts longer and it's a much higher dose and it has a much higher affinity. So if you're going to try it, my recommendation is to use this medication. It is FDA approved for sleep onset insomnia, and it is well tolerated. It has a very high safety profile. If you are concerned about substance abuse, if you have other agents on board, this is again a safe option to go. And it's available generically now, so it's going to be more affordable for your patients. And it's just simply 8 milligrams at bedtime. I hope you've had some positive experiences with this one, and especially because it's available generically now, it's something else that you could try. So let's move to the sedating antidepressants. Doxepin. So I'm going to confession for you guys. I kind of forgot about Doxepin because I'm used to it being a tricyclic antidepressant, anticholinergic, bad. And those are at the traditional doses of 75 milligrams a day. Well, this medication has been studied and FDA approved for insomnia, for sleep maintenance insomnia, but it's at a tiny dose at 3 to 6 milligrams at night. And it has a strong binding to histamine 1, but no other neurohormones are affected at that very low dose. So the studies show just for sleep maintenance, it could be a well-tolerated and very low risk of next-day impairment medication option for you. So again, this is something that in all of my reading with insomnia, I have to admit to myself that I kind of forgot about. So I'm hoping that you can remember that for a certain subset of patients potentially. Trazodone. I bet way back that your number one medication that you were prescribing was trazodone. Well, I'm here to tell you that even though we don't fully understand its mechanism of action and why it, quote, treats insomnia, what all of the societies say is that at doses under 100 milligrams, it does produce some hypnotic effects, but there's very limited efficacy, evidence, and safety for insomnia. It's not FDA approved for the use of insomnia or sleep disorders, but yet it remains one of those that we tend to use. So you're going to see from the societies that they don't generally recommend it. And then lastly is our mirtazapine. And I would say that if you have a patient that you're treating for depression, this could potentially at low doses cause enough sedation that it could help with someone's sleep disorder. This is your serotonin modulator that we think about that can cause drowsiness and increase appetite. And we know that at the low doses, it does bind to enough histamine receptors that it can produce some drowsiness. It is not FDA approved for insomnia, however. Okay, so sedating antidepressants are done. Now let's see how Mrs. L is doing. During her follow-up visit, Mrs. L agreed to stop scrolling through her phone in bed and to turn off her TV. So she returns 1 month later. She's doing that successfully. She started listening to white noise instead of having her TV on. She joined a local gym, started a senior adult class 4 days per week at 5 p.m., and that has helped with her loneliness. Her sleep diary still shows, however, only 5 to 6 hours of sleep a night, and she really is being affected with some daytime fatigue and drowsiness. So she's following all of what we're saying to do. She's coming back. She's trying really, really hard. So what do the guidelines say? Do we have good guidance? There are 3 that I'm going to present to you. The first one is the American Academy of Sleep Medicine. It is the gold standard in the U.S. The only problem with it is the last guidelines were published in 2017. So they're a little dated. So on your left, let's go through that. The strong recommendation, is going to be CBT insomnia. That is the gold standard. But they gave weak recommendations for temazepam and azopiclone, sorry, I have a hard time saying that one, and zolpidem, and also for zaleplon, Melatonin, triazolam, doxepin, and suvorexant. Now, it's important to know that these 3 are for both sleep onset and maintenance. These are only sleep onset, and at the time of this guidance, doxepin and suvorexant were for sleep maintenance, and that has since changed. Suvorexant is FDA approved for both sleep onset and sleep maintenance, but this is kind of how they differentiated it at the time. So these are weak recommendations. But what they did not recommend is diphenhydramine, the herbal supplement of melatonin, and trazodone. Okay, and that was back in 2017. Now, in 2019, the VA, the Department of Defense, also released very similar guidance, again, strong for CBTI, but weak for doxepin and the Z drugs, but weak against, that's interesting, diphenhydramine, melatonin, any antipsychotic, any benzo, and trazodone. They said that they could, based on limited data, they could not recommend for or against both Melatonin and suvorexant. So this is back in 2019. But they did, it was interesting, they made a strong against statement for kava. Now, I haven't talked about herbal supplements. We don't really have time to talk about it, but I did want you to know that kava is associated with hepatotoxicity and equaling liver transplant. So when you have a patient that comes in and they have their supplement of choice that they're using for their sleep disorder, my general approach to supplements is I want to ensure their safety, and hepatotoxicity is the number one problem, okay? It might be where it's originating from. It might be that it's not a trusted, it may not even be kava. You know, I really struggle with knowing what is in a product that's not FDA approved and mandated, that they don't even have to prove what's in it. But if it says kava, I'd like for you to remember to say, please don't take this product. Can we switch to something else? Because the liver transplant list is actually pretty long with this particular supplement. So because these were somewhat dated, I did want to include something that was just published a few months ago, the European guideline update. And they specifically said we wanted to look at all of the updated evidence and try to put in the latest information. Again, the strongest recommendation is for cognitive behavioral therapy with insomnia, so that whole bundle, remember that whole insurance. Now, they divided it up. For less than 4 weeks, they gave a grade A recommendation for both benzos and benzoreceptor agonists, or your Z drugs, daridorexant, and the low-dose antidepressants they gave a grade B to. So the highest level of evidence for short-term, okay? Now, when you go to 3 months, they gave a grade A recommendation to the DORAs as a class and a grade B for Melatonin. So I do feel like, and when I reviewed this data, I agreed with their assessment that there is enough evidence from randomized controlled trials for both short-term and longer term. Now, we don't have 3-year data. Okay, it will be a while, but we do have 3-month data, and there actually is publications for 6-month data. So that's encouraging for both the DORA class and Melatonin. And again, they did not recommend antihistamines, antipsychotics, and melatonin. Okay, so we kind of have this kind of theory that's going along with all 3 of them of things that are not recommended. Okay, let's finish up. Special patient care considerations. So I made this chart just so you can kind of see the differences with sleep onset, sleep maintenance, vulnerability to substance disorder, and then the need for normal next day function when you're really trying to differentiate your patient. You can see here that the DORAs go all the way across. Doxepin, if sleep maintenance is a problem, is certainly a safe choice. So this is just something for you to refer back to when you're trying to differentiate what's going to be the best medication for my patient. Okay, second knowledge question. What is a medication shown to improve sleep onset, sleep maintenance, have a low risk of next day impairment, and rebound insomnia or withdrawal? And, D, the correct answer is C. But I bet a lot of you wanted to pick D. That's certainly what my residents would pick. They said that does not exist. And I'm not saying that they're not potential adverse effects. Anytime you take any medication, there is a potential for adverse effects. Ideally, it's best to take nothing, right? But for all of these indications, daridorexant is the most effective. As stated in the AASM and the VA recommendation, trazodone is not recommended due to lack of efficacy and safety data in insomnia. Melatonin is not indicated for, for sleep onset. And the other option that I didn't have on here that you could potentially say if you didn't need sleep maintenance is going to be doxepin. But daridorexant is going to be the best option in this situation. Okay, so back to Mrs. L. At the last visit, she was encouraged by making all these hard lifestyle changes. She was encouraged to continue. She even agreed to a sleep restriction week during her the school spring break. She did that effectively, and she's returned 1 month later, and she does report some improvement, but she's still struggling several nights per week. She has fatigue during the day, and now she's finding it hard to even make it to gym class, and that is not something that we want. We want her to continue to exercise. We want her to work out her grief and her loneliness by being out and seeing people that are like her. So it might be time to discuss medications with her. So based on the guidelines, what medication has the highest evidence for efficacy and safety for Mrs. L? And again, I have to say the answer is going to be daridorexant. That is because of both sleep onset and sleep maintenance issues that she was having, the need for early morning alertness with her job. These are going to be this is going to be the best option for her. Okay, I'm almost done. Last slide, I promise. Number 1, these are your takeaways. Please discuss sleep with your patients. It is important. I know it's not fun, but if it's that important, make another visit for it just to discuss it. Counsel on good sleep behaviors and strategies. Admit to them what you don't do very well. It always works out better for me. And it helps me to actually be a better sleeper myself whenever I have to educate someone else. Trying to come up with all these slides, I really had to do a deep dive on being introspective of what I'm not doing correctly. When it comes to selecting pharmacologic treatment, you really have to individualize and you really have to use shared decision making and pick the appropriate medication in addition to behavior. So I hope that I gave you some strategies and some facts that will help you lead down that path, but each individual patient is going to be different. And finally, follow up with them and ask them the questions and keep working on it. Even if they failed cognitive behavioral therapy one time, go with a different regimen. Just try to keep it on the radar because we know the consequences of insomnia are real. So our goal is to improve patients' lives. They want to live healthier, happy lives. So I hope that I've given you some strategies to help with that. Okay, so in summary, I hope that you have in fact learned just a little bit about the physiology of sleep and wake. Remember orexin and GABA. I hope you will identify your patients. Just ask them, okay? Go through a sleep diary. Use some of the indexes and the questionnaires. Pharmacologic treatment. Go back. Don't try to remember all of this. Go back and look up the information and make sure that you give them all the information and make sure you ask the hard questions. You need to ask about substance use, alcohol use disorder, depression, anxiety. You need to ask about all these things. And then I want you just to consider the DORAs because this is a relatively new class, but not really. It's been around long enough that we have really good data with it. And I would say in the whole scheme of the pharmacologic management, a lot of efficacy and safety with that class. Okay, we are finally at the end of our pharmacologic management of insomnia. Please see this QR code or the URL below for a post-presentation survey. I will give you a moment to get that information down. I so appreciate your attention and your interest in this topic.